Good evening, ladies and gentlemen. Welcome to this faculty session. It's indeed a privilege and pleasure to have Professor Gurushanthappa, who is an excellent teacher from what I know. I have seen him over the years, and I think we must consider ourselves very lucky in Saga department to have him mentor our youngsters. As you know, not only do we need to know the subject, but there is a technique for passing the exam also. And I always feel that, professors in the mainstream, MS stream, for example, like Professor Gurushanthappa, they'll be the best mentors for all our students in as far as teaching them and mentoring them about what is expected in the exam. And that is an essential part of your training. Without taking up much of the time, I now leave the floor open to Professor Gurushanthappa and Nikitha, who will, I presume, be presenting a case about an inguinal swelling. Over to you, sir.
Thank you. Yeah, Nikitha, you can start the case. Anyway, I thank Aster Group and Dr. Lakshman and his team for this opportunity. And even my postgraduates from my institute and another two institutes where I have forwarded the link will be joining the program, sir. Thank you, sir. Please, Nikitha, you can start.
Yes. Good evening, everyone. Case presentation. A 68-year-old male, former by occupation as a resident of Kolar, came to OPD with the chief complaints of swelling in the right groin since 1 year and pain in the right groin since 1 month. History of presenting illness. Patient was apparently well 1 year back and noticed a small swelling in the right groin, which was insidious in onset, gradually increasing in size, currently reaching mid-scrotum. Initially, it was spontaneously reducible, but since 1 month, it is not reducible. Patient has an history of recent onset of pain over right groin since 1 month, which started after he had a cough for 1 week. Pain was dragging in nature, intermittent. It lasts for few hours, aggravating on walking and relieved on lying down or taking rest, which is non-radiating. There is no history of urinary urgency or frequency, nocturia or straining. No history of constipation, no history of weightlifting or history of chronic cough. There is no history of vomiting, abdominal discomfort or distension, and fever with redness over the swelling. No history of similar complaints on the other side. Past history is not a known case of diabetes, hypertension, cerebrovascular accident, ischemic heart disease and asthma. No surgical history. No history of cough or cox contact. No medication allergies. Patient is not on any regular medications. Personal history. Patient has normal appetite with mixed diet, no bladder or bowel disturbances, has adequate sleep, and he's a non-smoker. Family history was insignificant. To summarize
no
the history,
no history of cox contact DNB student.
Sir, Gurushanthappa sir, Ravi Shankar here. Good evening.
Yeah, good evening, Ravi Shankar. Good evening.
I think when, for example, he has no comorbidities, will it not suffice to say the patient has no known comorbidities and family history is insignificant, but I think family history is not contributory. I think that may be a better word. What do you think, sir?
Yes, sir. I thought of coming back to each slides after this summary slide. Yeah, definitely. Yeah. Rather than mentioning, yes, previous slide, Nikitha. So, yeah, he's right. Contribution from the family history, if it is there, yes. Otherwise, maybe that is a better option to use. And general, like other contributory factors, if it is there, you highlight. Otherwise, you can finish it off with a single sentence that he doesn't have, like, what are all the points you have mentioned in that slide, previous slide.
Okay, sir.
And I did not understand that previous slide. Cock and Cox contact, previous slide. Yeah, I just curiosity, what exactly you wanted to highlight? No history of Cox or Cox contact. What is that? You mean
So currently
tuberculosis
no history
ultimately?
of cough, but there was any previous history of tuberculosis or any contacts of them.
To make it simple, yeah, like tuberculosis, either contact or having been treated. We shall come back to the first slide.
Tanya, just mute everybody. Tanya, please mute everybody.
Okay, sir.
Anything can you draw a conclusion with chief complaints, only chief complaints?
So from that we can say it was a chronic swelling, but currently he's having pain. That means that it's going into complications now.
No, don't keep hernia in your head and answer my questions. You don't know anything about this. You are listened to this chief complaints. You are not asked the remaining details. So anything can you think of like that? Unbiased, only these two chief complaints. What I want to know is unbiased thinking to your brain. Like, yeah, it's a swelling of 1 year and pain since 1 month. Could this be justified with a lymph node swelling, keeping that hernia aside?
It can, sir. It could be some infectious sebaceous cyst also.
Okay. Not infectious, infected.
Infected.
If at all, if you want to
currently
substantiate.
infected. Yes, sir.
Okay, okay. Yeah. No, why I'm asking is sometimes these things unbiased, like logical explanations may be asked, even though it's a straightforward case which you're going to present. Keep it like for discussion. Yeah, could be a lymph node staying there and now it is forming an abscess. Probably, yeah, maybe a possibility. At this, only these 2 points, if the question is asked. You got the point?
Yes, sir.
Next slide, you have mentioned reducibility in the history. So we insist that don't use this reducibility word at history level because it is going to be your examination finding and patient may not be knowing what is this exactly. So it is better to use some other word for this, appearing and disappearing. Okay.
Okay, sir.
So not to use the reducibility word at history level. Okay. So there is a
Yes,
history that when the patient lies down, the size comes down and he stands or strains, the swelling becomes big. That's what he will be mentioning about.
Got it, sir.
Okay. Yeah, fine. So ultimately, with these two things, what is that you want to highlight, which was coming down in size, increasing, and then now since last month, 1 month, it is remaining stagnant, like in the form of a swelling.
Yes, sir.
Okay, so what is that conclusion now? Obviously. I'm
It has
not
become
able to hear you.
irreducible, sir.
Okay.
Nikita, please
So
go
hernia
ahead
is-
and go ahead and say what you have to say. Don't be inhibited. Even in the exam, even in a clinics like this, it's not wrong to make, particularly in a training session, not wrong to make a mistake. Please say something. Silence is not something that is received well by anybody, anytime. Please say
The
something.
reducibility, yes, sir. The reducibility suggests that it was a hernia, sir.
Okay.
And it being non-reducible says that
Incarcerated,
incarcerated.
possibly incarcerated.
but I will appreciate the word, sir. It's like you said half of it rightly, half of it, that first half. Yes, because there is a history of decrease in the size of the swelling on lying down, obviously hernia. And second, since last one, it is not. Sir, probably this hernia is going for complications. What exactly we'll see later. But this point of time, going for complication. What exactly we'll decide later. Okay. So
Yes.
one of the complication is irreducibility. Causes for irreducibility, plenty, that you will come to know after examination and after some investigations. Is it not?
Yes,
So
sir.
probably it is going for a complication or probably patient has got a complicated inguinal hernia at present, at this point with this slide. Okay. When you have mentioned non-radiating, is it worth mentioning a radiating or a non-radiating pain in an inguinal swelling? Or any particular swelling you would like to highlight this point?
So it could be radiating if it could be radiating to the umbilicus, sir. If bowel loop is involved and
Is it?
mesenteric drag is there, it could.
Is that called a radiating pain? If there is a momentum stuck there and it is pulling down, and patient will have some discomfort in the umbilical area, do you label that as a radiating pain in a case of groin hernias? No, it is not.
No, sir.
So if you are talking about groin hernias, and if somebody asks you what is the meaning of this radiating pain, a relation of this with those groin hernia, it is a femoral hernia which is typical, or an obturator hernia which is typical. Okay, typically it is seen in obturator hernias. In
Okay,
fact, you will have some competitive examination, some questions on this. They will give some scenario of radiation and what is a likely hernia. So it is a obturator hernia we get, otherwise not in groin hernias. Okay, so try to avoid this using radiating pain in groin hernias. Okay, next here.
I think
Yeah, Ravi Shankar.
Nikitha, you always have, I think the power of editing, I keep telling you guys, you have to tailor the, whenever pain is mentioned, it's not necessary that radiation has to be mentioned all the time. If it is
Correct.
not relevant, you don't have to mention it. That is the important aspect of it. If there is radiation and if the final findings actually correspond to the swelling or whatever that radiates, then you can use a word. Otherwise, you don't have to.
What Ravi Shankar wants to highlight, it should be relevant and it should help us for some diagnosis in that particular given case. Then only you should highlight. Okay, you should not mention what all mentioned in the books about particular symptomatology. No, is that symptomatology detail relevant to this particular case? Then only you should highlight. Even if it is negative, it is going to help you out, you should mention that point. Otherwise, there is no need to mention everything on a particular symptomatology.
Yes, sir.
Fine.
Carry on, Nikitha.
Okay, fine. Next. So at history point of at history level, you are thinking in terms of probably it was a inguinal hernia earlier. Now it is going for
Yes,
complications. Okay. These are all the precipitating
sir.
factors you have asked for.
Yes.
Okay. Is he a
Yes, sir. First
smoker?
4 points were regarding the precipitating. He's a
Is he a
non-smoker, sir.
smoker? Okay. You have mentioned anywhere this point?
In the personal history, I had mentioned it, sir.
Okay. Fine.
Okay,
Fine.
go to summary. Go to summary now.
Okay.
So a 68-year-old male, former by occupation with no comorbidities, presented with a swelling in the right groin since 1 year, initially reducible, now irreducible, extending into scrotum, associated with the dragging pain since 1 month, which aggravates on walking and relieves on lying down.
So I think you should incorporate what Professor Gurushanthappa said. Yeah, that initially the swelling was, reducible. Usage is probably not right at the stage of history. In the clinical examination, you can use it, I think. So you should use some other term. The swelling would disappear initially on lying down posture, which now does not. Or the swelling used to be transient and now persistent. So something like that you should use so that you don't use the word reducible. I think I think Professor Gurushanthappa has probably seen some of the examiners take exception to this, which is why he is telling you. I think personally he may not really mind this, but he has seen other professors who are very pedantic and they insist on such things. So he is telling you that these are the good points that you get from listening to Professor Gurushanthappa. Okay.
No, better you can use increase in size of the swelling or decrease in size of the swelling. That is the best answer.
Yes, sir.
Yes.
Nikitha, the principle there is that you describe the symptoms in the patient's words.
On words.
Understand? So patient will not say it's reducible or irreducible. He'll say it will decrease in size or disappear. So at the history level, you talk as if the patient is reporting. And at the examination level, you can go on to the doctor's jargon. Please continue.
Yes.
Yeah.
General examination, patient is examined in a well-lit room with adequate exposure. Karnofsky score of 90, and patient is conscious, coherent, and cooperative. So he is moderately built, well-nourished with a BMI of 22.5. There are no signs of pallor icterus, diagnosis clubbing, chylomicrotia, generalized lymphadenopathy, pedal edema, or any skeletal deformity. Vitals pulse rate was 84 beats per minute, measured in right radial artery in lying down position. Respiratory rate 18 cycles per minute, abdominothoracic. Blood pressure 120 by 80 millimeters of mercury, measured in right brachial artery in supine position. And temperature 98.3 Fahrenheit. Local examination, patient is examined with due consent and adequate.
One second before local. Put that GP second slide. Previous slide. Yeah. Second slide. Next slide.
Next.
No, next. Yeah, wait. I don't know. Absolutely, according to me, for this case, this slide is really not required. Maybe patient, if he has got a history of smoking, cough, expectoration, if he has in the history, you need to highlight one is clubbing in this. Okay, maybe pertaining to this case. Otherwise, remaining all points in this slide probably doesn't carry any contribution to the present case. Okay. So COPD, if you are suspecting, yes, clubbing, something you need to highlight. Okay. Previous slide.
Sir, is it acceptable to say general physical examination was normal?
Not normal. There are no obvious
No.
findings in the general physical examination which are contributing to the disease. Exactly. Yeah, definitely. Single sentence, because it is a short case and nothing much to be discussed. Definitely. Even writing Karnofsky score for inguinal hernia, people may question. Okay, only the point I wanted to have a question is, what is the relevance of BMI, mentioning BMI in this case? Is it relevant? How?
Yes, sir. Obesity will be a contributory factor to the hernia. So we have to mention BMI to state that it is not the conclusion.
Correct.
To plan the surgery, sir.
Exactly. So obese people, even with a groin hernia, you need to plan. You cannot just go ahead with whatever the remaining patients we do. Okay. These are the 2 points where BMI is really important. If you are going to have obesity, maybe plan of treatment may vary, whether you are going to have an open or a laparoscopic approach for a treatment. Okay. And that itself is a contributing factor. Okay. Fine. Next slide, local examination straight away.
Patient is examined with due consent and adequate lighting, exposed from nipple to mid-thigh in standing and lying down position. On inspection on right side, pyriform-shaped inguinal-scrotal swelling is seen, which measures approximately 18 to 6 centimeters, extending from above lateral part of inguinal ligament to mid-scrotum. The size of the swelling increases on coughing. Overlying skin is normal with no redness, dilated veins or pulsations, peristalsis and scars. No reduction noted on lying down. Penis is central in position. Other hernial orifices are normal. On palpation on right side, inspectory findings are confirmed. There is no local rise of temperature. Generalized mild tenderness is elicited. Pyriform shaped swelling of 8 into 6 into 4 centimeters is noted, extending from above lateral of inguinal ligament to mid-scrotum, which is soft in consistency and expansile on coughing. Testes could be felt separately, cannot get above the swelling. No phimosis noted. Other hernial orifices normal. Other tests like deep ring occlusion, Siemens 3-finger test and finger invagination test could not be done as the swelling is not reducible. A taxis not performed in view of tenderness. Percussion not done due to tenderness. Auscultation, no peristaltic sounds are heard. On left side, inspection and palpation done. No swelling or cough impulse noted. Digital rectal examination not done. Examination for tone of abdominal muscles is done, which was normal. No malignant bulges were seen in leg and neck raising test. No other protrusion seen in the lower abdomen on standing. Systemic examination, respiratory system, cardiovascular, and neuro central nervous system.
This is normal. Anything in the systemic examination?
No, sir.
Okay, you come back to the Ravi Shankar, there are a few points which, like our undergraduates, do some mistakes. Nikita, there are a good number of points which probably for a inguinal swelling I may not encourage. Few of them is you have mentioned about erythema, tender, this thing. What is that? Next slide. Scars,
Redness,
erythema, and dilated veins, pulsations. These points only if they are there, you should highlight. If they are not there, don't highlight. Don't highlight. Even in the history, you have mentioned about that redness, patient appreciating redness. Okay. So it is
Yes,
not required. We can understand your point of mentioning this, like a stimulated hernia, but if it is there, you need to highlight. If it is there. So otherwise, you'll be inviting. When do you get a dilated veins in a inguinal hernia? So like that, it will start. Okay. So best way, and you
yes,
said there he has not undergone any surgeries in the past. So where is a question of
yes,
mentioning about scars? Okay. Absolutely that is not required. These points for this particular case. Okay. And position of
yes,
the
sir.
penis hardly matters. Again, this should be taken out from the books itself. It doesn't contribute anything, even if it is a large giant hernia. Okay. Yeah, buried penis, yes, maybe. Otherwise, position hardly matters. Okay. Next slide.
Yes, sir.
In
Next
your
slide.
slide, you have written, no, overlying skin is normal. Then why you are writing all no redness, dilated
Correct.
veins?
Correct.
See what Nikita, basically you will never get in the exams, you will never get a complicated, obstructing or strangulating hernia. So I think all these points are probably not necessary to be mentioned. If I think if you say overlying skin is normal, that is sufficient.
Normal. Correct.
Yes,
Next one. You have mentioned the extent as mid scrot.
yes, sir.
Okay. Is it not?
Yes, sir.
Okay. You tell me what position you did inspection, in what position you did palpation of this case.
Sir, inspection was done in both standing and lying down position, sir.
Okay.
Palpation is also done in both positions, sir.
Question means I am not asking about the test. Before doing the test,
I didn't get you, sir.
you have done some test, no? Which you have mentioned in the next slide.
Yes, sir.
Oh, okay. In this case, it was not done because of the reasoning. Okay. So in that palpation, is it always in the supine position?
No,
Because
sir.
you have mentioned one of the tests where getting above the swelling is not possible.
Yes, sir.
Okay. So if you say the swelling is extending from the groin area to upper part of the scrotum, is it really required to do this test? Getting above the swelling. Anyway, it is not
Need
required.
not, sir. Need not, sir.
Doing this test is not required for this case. Okay.
Agree, sir. Yes, sir.
Yeah. Okay. Fine. And you said doing the test, which position you did? Reducibility, deep ring occlusion test. In this case, not possible. But in which position will you do?
If we do, usually first we'll inspect the patient in a standing position. Then we ask him to lie down. If it spontaneously reduce a little, it's fine, sir. Otherwise, we reduce the swelling in a lying down position. Then occlude it and ask him to stand. Then ask for a cough impulse, sir.
Okay. Ravi Shankar, I don't know, I may be wrong, but in my institute, the teaching is we don't do this. In the sense, it has to be done, test has to be done in supine position only.
Yes.
If the swelling is reducible, reduce the swelling first, occlude the thing. Don't make him to stand again. That is written in the
Yeah.
books, but it is wrong. Don't make him to stand. By the time he stands, your finger will be somewhere else. So occlude the finger, ask him to cough. Look for the cough impulse. So witnessing the cough impulse is the positive test. So that has to be done in supine position only after occluding deep inguinal ring.
Agreed, sir. I think that is correct.
Yes.
And I think even from patient point of view, making him lie down, I think you examine him once when he stood up and examine him once when he is lying down, because
That's-
patient comfort is extremely important. Thank you.
One more point I would like to ask about this. Here, cough impulse, it is expansal cough impulse. So I think for that reason in the book they are written in the standing position. To get expansal cough impulse, he has to be standing position.
Sir, but you can make out expansive cough impulse even on lying down posture, because you can, once he coughs, the swelling
When
comes out. Yeah,
hmm.
swelling comes out.
No, that's what. When it comes out only, then only we can feel for expansion. When he stands only, that will come out normally. Then you feel that that is expansal. That is my interpretation. And one more, this Nikitha, pyriform shape you are written 8, 6 into 4. Three-dimensional view you
Yes.
can get in palpation.
Sir, on palpation, we could make out a certain amount of depth also, no, sir, like height.
How can you make out? If it's a hanging or pedunculated, you can make.
The portion which was coming into the scrotum, that depth, the size of that, sir, that portion.
Think and tell, no. It's not possible, no. Part of the swelling is only in the scrotum. You have written there, from where it is started?
Yes, sir.
Inguinal region. No, I don't know. I ask other.
I think what she mentions is, I think you take the length of the swelling, the breadth of the swelling, and also if you place the tape where the swelling is on the surface and go up to where it is visible or palpable, and that I think she's mentioned that as the third dimension. I think it is probably not a big fault to mention that. I think, sir, Gurushanthappa sir.
Two dimensions are more
Not
than enough.
clinical
If you
examination.
can,
That is
yeah.
radiological, they can mention. Clinically,
Only
it is
two
difficult.
dimensions are more sufficient. Only two dimensions.
Okay,
You have
sir.
mentioned no phimosis in an aged patient 68 years. Can you expect phimosis? One, if he has phimosis, what will be your thinking in a man aged 68 years?
Sir, it could be recurrent balanoposteitis, which results in phimosis in that age.
Okay,
Can
68 years. Secondary to balanoposteitis, invariably secondary to what? What disease? It is common in which people? Diabetes.
diabetic, yes, sir.
Yeah, presentation of diabetes could be balanoposteitis. Okay.
Yes.
So it is in the middle age, not elderly of 68 years old. So is it common phimosis?
I'm not sure of, sir.
No.
Phimosis
Other
is
way,
a childhood disease. Okay. In an elderly patient, if a person has got phimosis, is inability to retract the prepuce. Okay. So what will be your thinking if he comes
Yes.
with that history, and if you have diagnosed, you are not able to retract? So what will be your thinking other than balanoposteitis? Anything you should keep a serious disease in mind?
Yes, sir. Any penile lesions with
Penile cancer, you should keep it in mind. That is more
yes.
common than balanoposteitis. Okay, so feel for induration inside. Feel for induration. Okay. Anyway, because you have written, just I brought this point. Don't mention phimosis in an elderly. Okay, fine. Next slide. Okay. Personally, I feel Siemens test we don't encourage to do, because you are able to differentiate direct and indirect by good test. That is the deep inguinal occlusion test. And the femoral hernia is entirely different entity. So simultaneously with three fingers, making the patient stand, making some position, it is a very very discomfortable for the patient. And also information what you get is not for the diagnosis, so not to be done. Finger imagination, because it causes pain, we don't. So only test which we may encourage clinically for inguinal reducible swellings is deep inguinal occlusion test. That's all.
Correct. I think
Okay.
absolutely.
Yes. Fine. And you have highlighted this. I appreciate this last one, that these tests, that is a deep ring and occlusion test, could not be done because the swelling is not reducible. Fine. Next slide. Fine. What is the diagnosis now?
Sir, diagnosis would be right.
Why did you examine on the left side?
So there could be small swelling which patient might have ignored,
Okay.
and most of the times in an elderly patient, there could be bilateral hernias.
Okay. You wanted to check for bibinocele? You want to say like that?
Yes, sir.
Okay. What is occult hernia?
Occult hernia, on clinical examination, there would be no findings, but either radiological or intraoperative, we can find the hernia, sir. That would be occult hernia.
Intraoperative means it is basically laparoscopy.
Yes, sir.
Yes, it is a intraperitoneal laparoscopy. When you do, you may see a hernia, more commonly seen in children. The incidence of occult hernia, it is almost nearing 50% in childhood. That is why laparoscopy has got an advantage treating by laparoscopy in childhood. Okay, treating hernias by laparoscopy. Okay.
Yes, sir.
Okay, fine. And you have mentioned for next slide for looking for Malgagni bulgings. You have mentioned both head raising and neck raising. You have to be little careful. You have to be little careful to check for Malgagni's bulgings. Which is the test done?
Sir, leg
If you
raising
raise
test.
both, if you raise both leg and neck, will you get the test done?
No, sir. Either legs or neck.
Or neck also can be done. Where are the Malgagni's bulgings?
Sorry, sir.
Where are
Only
they?
neck could not cause the abdominal muscle.
Exactly.
Yes.
Above the umbilicus, upper abdomen. If you want to make the muscles to get taut, head raising test. It is not the neck, it is the head you are going to raise.
Okay, sir.
Not the neck, head. Okay. See, unnecessarily, you should not invite some silly questions from the examiner when you use the words. Okay. So lower abdominal muscles, it is a leg raising test. And in case of like this, if you really want to check, we want the lateral aspect of lower abdominal muscles. So leg raising test,
Leg
very
raising.
simple. Okay,
Okay, sir.
fine. Next slide. Fine. You have mentioned authentically that the PR not done. Like anything you wanted to highlight that, or it is?
Sir, if we had done, we could have looked for any prostatomegaly, sir.
Okay.
That's
So why it was
main-
not done?
The patient was not comfortable doing it when.
Fine. Okay. Diagnosis.
Sir, it's a right inguinal, indirect, irreducible, incomplete, complicated hernia with possible content being omentum, sir.
You tell me logically, is your diagnosis sentence what you have written is right with a previous description which you have given it to us in one of the slides? I will ask you to analyze yourself.
I think it's consistent with the findings, sir.
No, you have mentioned some finding in the previous one or two slides. Your diagnosis is not substantiating. It is wrong what you have written here. What is that being wrong?
Nikita,
Okay, how did
you are
Yeah,
not
Ravi
able to make a differentiation between direct and indirect because
exactly
deep ring occlusion test was not possible because the hernia was not reducible. So you can't say this is an indirect, but
indirect hernia?
Can we go by the shape suggesting, sir?
No. Direct, indirect, it is by that test clinically. Even if it is obstructed, non-obstructed, whatever. If you are using these words, you should do that test and label that diagnosis. Otherwise, best way is it's an irreducible inguinal hernia.
Should I mention while telling diagnosis that it probably indirect, or sir, should I completely do not mention it at all?
No, not required because you have not done that test. You could not do it. Sir, Lakshman sir?
One more thing, Nikita, even though
Yes,
you
sir.
have written this, you can still justify. You think over the size of the hernia.
Inguinal scrotal is usually indirect hernia, sir.
Not in the inguinal scrotal. Both are inguinal scrotal. Where it is in a hernia?
Sir, from the lateral portion of the inguinal ligament to mid scrotum. Sir.
Where? Up to
Mid scrotum, sir.
mid scrotum. You expect anytime direct hernia to descend so much?
Usually not, sir. Yes.
That's what. See, we teacher, a faculty may ask, but when you are presenting anything, you can justify it. There should not be contradiction.
Yes, sir.
You can tell like that. And contents I do.
Okay, your diagnosis is you are written European Hernia Society PL3.
Sir.
PL3, yeah. It's a primary hernia.
Yes, sir. Primary hernia.
Okay.
The history lateral had taken.
Okay.
3 being the size of the defect, sir.
How did you make out size of the defect?
Usually we have to do it by insinuating the fingers into the defect space, but considering the large size of the
So complicated inguinal hernias are classified in European Hernia Society by any means?
No, sir.
Sir, Lakshman sir, just you want Ravi Shankar?
Yeah, sir. Yes, sir.
Sir, in this classification for groin hernias
Yeah.
by EHS, if it is a complicated hernia, because there it is L1, L2, L3, primary and recurrent, depending on the size 0, 1, 2, 3, and X. So in that complicated, nowhere it is the point of discussion. So what exactly? Because she has taken L3 without measuring the defect size.
Yeah. This would be an approximation, but I think she has taken the size of the swelling itself to say that it's probably L3. You know, it's a bigger size. But to be accurate, it's not possible to be accurate about this. So
complicated hernias, I think they cannot be classified in EHS.
Yeah. So
as far as my knowledge goes, if it is a complicated hernia.
Yeah. It's probably better to skip this, Nikitha. Don't mention the
Exactly.
EHS classification.
Exactly. Okay, next slide. Anything you have mentioned in the next slide?
No, sir.
Okay, fine. Okay, well, how do you want to manage? Yeah, fine.
I would like to confirm the diagnosis, sir. So initially we'll advise for an ultrasound abdomen and pelvis to look for the hernia, to classify this, to look into this hernia, and also to look on the other side and to look for the prostatomegaly, sir.
Yeah, see, it's a complicated hernia now. It's not a just inguinal hernia. So what is that you exactly want from the ultrasound?
We want to know the defect size and also the contents of the hernia, sir.
Okay. Defect size in a complicated hernia, it hardly matters because the priority is the treatment. Okay. So you would like to know what is the content. That's all. Like momentum or a bowel that can be made out on ultrasound. Otherwise, ultrasound, yeah, like prostate you mentioned. Otherwise, further diagnosis, probably ultrasound may not be the investigation. It's a clinical diagnosis, what you have made.
Yes, sir.
Nikitha, it may be more useful for you to specify what you're looking for as far as prostatomegaly is concerned. Is your primary concern the size of the prostate that they give or something else?
The post-residual.
Yeah, why don't you be specific when you mention it, please? Post-void residue.
Yes.
So just the size per se is unimportant. What we look for is the post-void residue. What is considered a significant post-void residue?
Greater than 50 ml, sir, usually.
50 is very, very conservative. 100 ml is more like it. Okay. So
it is usually represented as a percentage of the pre-void volume.
pre-void volume.
So it should be more than 10%. That is considered significant. And also you should also mention about the bladder wall thickness and
Trabeculation.
trabeculations, which will tell you that this is a chronic process going on.
Sir, Gurushanthappa, sir, please go.
Yes, sir.
Yeah. Okay. Anything else you would like to have investigations?
So further routine blood investigations to look for the fitness for the surgery, sir.
Right. Chest X-ray. It's important. Elderly man.
Yes, sir.
Okay. For anesthesia point. Okay. What is the treatment you would like to give it?
Sir, we would like to consider an open repair for the hernia, sir. Open Lichtenstein tension-free mesh repair in view of irreducibility.
Okay. Do you mean absolutely laparoscopy is contraindicated for him?
No, sir. If the expertise is available, we can actually try an laparoscopic repair also, and patient should be fit for the laparoscopic general anesthesia. We can try it, sir.
Okay. So what do you expect in the open hernia repair for this man once you open?
Hi.
Nikitha,
What do you expect?
please describe the operation when you are actually doing it. What is the advantage of once the patient is anesthetized? What happens?
Sir, abdominal muscle tone decreases, it becomes lax, and there is a chance that the hernia can get reduced on its own also.
Or you can reduce it yourself. You can reduce the
Yes, sir.
hernia. Yeah. Why is that relevant?
Sir, if the patient is not fit for surgery, we can actually give a local anesthesia and
No,
try
don't talk.
to just reduce it.
Don't talk.
No, don't.
This patient has no comorbidity. So why will we not be fit for surgery? He has absolutely no.
Nikitha, the question is, if under anesthesia also it cannot be reduced, is there a clinical significance, surgical significance of that? That's the question.
I didn't understand, sir.
No. When do you think it will become completely irreducible? With anesthesia, without anesthesia? What are the conditions where the neck is very small and what has come out is very big? Okay. Or what else happens when the swelling when that swelling becomes bigger than what it actually is? Additions can be there. What else can happen?
Loss of domain also could be there, sir, in case of
domain.
swelling.
No.
Don't use
going elsewhere. You're going elsewhere. If there is ischemia, what happens? It swells, right?
Necrosis, yes, sir.
Yeah. For that, there is an inflammation and there's swelling. And so the clinical significance is that if it cannot be reduced even under anesthesia, we should be a little more careful about the possibility of extensive adhesions or relative ischemia.
And
that's
also,
a point.
Sliding, if it is a sliding hernia, you will never be able to fully reduce it.
Yes.
So you have to be aware of that. So that when you plan surgery, when you are operating, you should be aware that there is a potential. As sir said, the bowel may be completely not reducible, or if it is a sliding hernia on the right side, it will be cecum or whatever, bladder. On the left side, the sigmoid colon and the bladder.
Yes, sir.
What is mass reduction, Nikitha?
Sir, along with the sac, the content gets pushed inside, sir. So the constriction will be continuous even inside the peritoneum even on reduction.
No, sac will not go inside. Sac will not go inside. Sac will remain in the same hernia site. It's a mass reduction. It invariably happens in ventral hernias, like after anesthesia, which is one of the dangerous entity. If the bowel is the content and partially gangrenous, and if this happens under anesthesia, and without checking, like if you repair the hernia, later patient may present with peritonitis signs. So mass reduction is one of the known entity which may complicate the procedure. And if we are trying for reduction on table after anesthesia, we should avoid getting a mass reduction done. You should be able to reduce the contents one by one and see that the bowel is viable before you release into the peritoneal cavity. Okay, that is a mass reduction.
Yes.
It happens. It happens in hernias, well known in ventral hernias. Okay,
Yes.
you just describe the procedure now. We have been asked to do this case. Just describe if findings are so and so, what you will be doing. I'll give the scenario that yes, there is a stuck momentum and partially there are gangrenous patches in the momentum. What will you do?
So preferably a partial omentectomy we can do it, sir. Excise the necrotic omentum and release all the surrounding adhesions and reduce the contents, sir.
Okay, next. What do you do for the
So-
hernia?
Sir, if there is necrotic patches, we preferably shouldn't use a mesh, sir.
Okay.
So we do the posterior wall repair.
You want to say tissue repair.
Yes, sir.
Okay. What is the preferred tissue repair method for inguinal hernias?
Sir, we can current usage is either Desadas or modified Scholdi's repair. We can try, sir.
Okay. Fine. You know what exactly they are? We will not
Yes, sir.
discuss. Okay,
Yes, sir.
fine. Okay. Basin is if you mention basin is also definitely accepted. Yes, currently tissue repair practice, Scholdi's is the first, and Desadas is the second method of preferred method of tissue repairs for inguinal hernias. Accepted. Okay. But
sir.
if the momentum is the here, it is partially gangrenous. If you have done a omentectomy, still mesh repairs are acceptable if the bowel, because nothing to do with the bowel. Okay. So still, the mesh repair with the Lichtenstein repair is acceptable. But if you mention tissue repairs, those two which are mentioned, definitely that is also the preferred method of doing a repair. Okay. Yes, everything is viable and you could reduce the contents. What is the preferred method in that scenario?
Mesh repair, sir. Tension-free mesh repair would be the preferable one.
Lichtenstein. Can you describe in single minute?
Yes, sir.
Describe the procedure. Yeah.
After a skin crease incision over the inguinal region, we deepen the incision into we get an external oblique aponeurosis. Incision is made along the fibers of external oblique aponeurosis. Then we enter the cremasteric box. So we separate the sac from the spermatic from the cord structures. Contents are reduced from the sac into the peritoneum. Then the herniotomy is done by ligating the sac and excising the sac. A mesh which covers minimum of 2 centimeters and maximum of 5 centimeters around the defect is placed over the posterior wall and fixed to the pubic tubercle medially and to the rectus sheath superior medially and to the conjoint fibers superiorly and to the inguinal ligament medially, sir. Fishtailing is done to accommodate the cord structures. Mesh is placed behind the cord.
Okay. I expect all the postgraduates, because you people will be doing the procedure. It's a common procedure worldwide, and because physically you will be doing the procedure, there should not be any hesitancy in describing the procedure. Okay. So it should be a fluent description of operative steps for inguinal hernia repair, Lichtenstein repair. Okay. What I expected, yes, once you say pubic tubercle, you should carry on to we carry on to the inguinal ligament, no, lower border. Okay.
Yes, sir.
Then rectus sheath medially. Okay. Then conjoint tendon. Then laterally splitting and creating a new deep inguinal ring. Okay. During the procedure, you should mention also taking care not to include the ilioinguinal, which you have identified before.
Yes,
Taking care not to include that. And
Yes.
external oblique aponeurosis closure, there are few points. Yes, medially not to tighten the external inguinal ring. Okay. A few important steps you should be in a fluent way. You should mention in this. Okay. Right. Any other procedures you know for inguinal hernia repair?
It's laparoscopic approach, sir.
Okay.
We can tap and tape total abdominal.
Here they said momentum is gangrenous.
If
Can you do mesh repair in this?
so, preferably we can go for a direct tissue
No,
repair, sir. But sir was saying we can.
both scenarios were given. So initially
Okay.
she said no mesh repair, and then the point was made that because it's the momentum and not the bowel, so infection risk is not high, and so mesh repair can be done. But what she described was the scenario given was that everything was, there was no necrosis involved, and it was the contents were
Straightforward
reduced.
hernia repair.
Straightforward hernia. Yeah.
Yeah. Just TEP versus STEP. Any points you want to mention, Nikita?
So nothing in specific, sir. Here the mesh will be placed on the behind the posterior wall. Covering the whole myopectineal orifice, which includes the direct, indirect, as well as the femoral hernial orifice.
Okay.
And yes.
What is the size of the mesh used there?
Sir, 10 to 15 centimeters mesh can be used, sir. If the defect is larger, we need a larger mesh.
No, I think minimum should be 15 by 12 centimeters when you are using it laparoscopically to cover the entire myopectineal orifice.
Yes, sir.
Every time you are taking the defect size, Nikita, I don't know, you are getting confused with ventral hernias. In groin hernias, we don't take the size, defect size and decide about the size of the mesh. Okay, so we know the fixed anatomy. It is an anatomy which we are treating because the problem is with the anatomy, which is fixed. There in ventral hernias, problem is with the defect size. Okay.
Yes.
So it's a fixed, like what Ravi Shankar was mentioning. Yes, for the laparoscopy, minimum 10 by 15 or 12 by 15 ideally. Okay, here 15 by 7.5 depending on the, like for open hernia, Lichtenstein repair. Okay.
Yes, sir.
So don't mention about the size if the defect size is so and so. No, not for groin hernias.
Okay, sir.
Okay, what is the advantage of TEP versus TAP?
Sir,
Generally, not particularly in this case, but generally, what is the advantage of TP?
Yes, sir. We need not fix the mesh like we usually do in a tap repair, sir, because it is in the pre-peritoneal plane completely.
I think
More important.
Nikita, it is better to use the term TEP and TAPP rather than TEP and TAP because some examiners may not actually like it. So you just
confusion also, pronunciation confusion.
So TEP and TAPP.
Yes, sir.
Yeah, we don't actually bother, but what happens is we are now talking about how you answer in the exam and you want to make sure that you pass. So better to not, irritate people.
Okay, sir.
So if you are given the choice of doing a laparoscopic repair, in this case, the swelling, the hernia is going to the mid scrotum, what would you prefer?
TP or TAPP?
Especially because it is
TAPP,
irreducible.
sir.
Correct. Why TAPP?
Because as it is irreducible, we are expecting difficulty in reducing the content, sir.
Correct.
And we need to visualize the content. It would be safer to do a TAPP, sir.
So you want to ensure that you are not leaving behind gangrenous momentum or bubble. See, for example, even though the content may be, momentum, there may be a loop of bubble behind it. And so you want to inspect the bowel and make sure it is viable and healthy.
Yes, sir.
So if you are given the choice of doing a laparoscopic repair, in especially because it is irreducible. Correct.
Yes, sir.
So
You are doing Lichtenstein repair, you have planned, and you will see part of the bowel wall is gangrenous. So what is that hernia called?
Sir, Richter's hernia, sir.
Richter's hernia. Okay. So what will be the treatment in such scenario?
Sir, is it completely gangrenous, sir?
I said no part of it, and you said
Part of it.
Richter's hernia. You
Yes,
have
sir.
defined the hernia.
Yes,
Okay,
sir.
straight away it is a tissue repair.
We have
Okay.
to go for a resection and anastomosis, sir.
And tissue repair. Okay. What is the difference in managing open hernia if it is a direct hernia and if it is an indirect hernia?
Excision of sac is not performed in a direct hernia, sir.
So what is done for the sac?
Strengthening, like double breasting, we can take sutures over the sac, sir. Strengthening of the
Is it
posterior
double
wall.
breasting what is done or what is done for the sac?
It's reduced, sir. It reduced into the abdomen usually.
What is done? You are reduced, but it will not stay there. No, it will just, if you push it inside again, it will come back. By the time you turn back, it will come back.
What is the word used?
Plication, sir.
Yeah,
Correct. Yeah.
application of the direct sac.
Yes, sir.
Okay.
See, Nikita, if it is a Richter's hernia, you don't necessarily need to do a resection anastomosis. You can, resect this, the part of the bowel that is gangrenous and then do a primary closure. You don't have to necessarily resect it. Only if if a segment of the bowel completely up to the anti-mesenteric border is ischemic, only then you do a resection anastomosis of a segment of the bowel.
Yes, sir.
That is wedge resection.
Wedge resection is the word used,
Wedge resection.
Yeah.
depending on the amount of the bowel that's gangrenous. Yeah.
If you take out the mesentery of that part of the intestine, that becomes a segmental resection. If you are not touching the mesentery of the bowel, you are touching only the bowel wall, that amounts to wedge
Wedge.
resection, where blood supply continuity is there. Simple.
Okay.
Sir, Lakshman sir,
Yeah.
shall we or?
I think we had a good session, sir.
Why do you have to suture this thing onto the rectus sheath?
Sir, usually to put it in position, sir.
As you work your way from the conjoint tendon onto the pubic tubercle, you will invariably encounter the lateral part of the rectus sheath. So you stitch to that also. Okay, that is the answer. Is that right, Srikanth?
Yeah, plus preventing the recurrence on the medial side.
Yeah.
Medial recurrence is
Yes.
extremely, yeah. So, Nikita, if this is a direct.
What is the material used?
Sir, proline mesh, sir. No.
Suture material.
Don't use a trade name.
Use-
Use the generic name. What is it?
Polypropylene mesh, sir.
Thank you. Yeah. Always, please remember that.
Yes.
Nikita, this is a large direct inguinal hernia. You said you have plicated the sac. What else will you do when you have, after you have plicated it? I keep, one of the things you have to do to prevent recurrence. What is it?
Sir, we take few bites from the transversalis fascia and suture it to the inguinal ligament, sir.
Yeah, that is plication, but you also have to do something else along the cord structure.
Give her the answer, Ravi.
Yeah, basically one is you have to, if there is lipoma of the cord, you have to excise the lipoma of the cord. And second is you have to ensure that there is no indirect sac, because that is one of
Yes.
the reason, even though it is a predominantly direct hernia, you can have a small indirect component as well. So unless you actually identify it, that is one of the reasons for recurrence of hernia.
Always you should look for indirect component.
Indirect component. Ensure that you go all the way up to the internal ring that is visualized by the change in color of the fat and also the inferior epigastric vessels. So you can see and make sure that there is no indirect component. So that is also a very important exercise.
Nikitha, define inguinalodynia and maybe what are the causes?
The inguinalodynia is the chronic pain post open inguinal hernia repair, sir, which is usually greater than 3 months.
Not
Is it
necessarily
only
after
relevant with the
open.
open hernia repair?
It can happen with both, but it is more with open, that's all.
Yes, sir.
What are the reasons?
Sir, nerve entrapment could be the reason, sir, or nerve division can also be the reason.
Any classification is there for the causes for pain? Depending on the etiology?
Not sure, sir.
Okay, what you mentioned is one of them. That is a neurogenic cause. There is one more cause called nociceptive cause. Nociceptive cause is inevitable with every surgeon, with every patient. Neurogenic cause is like preventable. Okay. So neurogenic cause, what you said, either in the form of a neuropraxia or taking the bites or cutting the nerves and the formation of neuroma, where it is in surgeon's hand and it can be prevented. The nociceptive cause, it is a process, inflammatory process, because you have kept a foreign body there. You have cut the tissues, you have handled the tissues, which is inevitable, which happens with every patient. So that itself can induce inflammation, fibrosis. So that can cause later the entrapment of nearby nerves. So either it's a neurogenic or a nociceptive. So how will you differentiate between these two so that you can predict, yes, is it going to be relieved after some time or it is going to be a permanent? Clinically, how will you find out?
Uh,
How do you differentiate between these two etiological or etiopathological process? Okay, we said neurogenic, no? So what is a typical description of any neurogenic pain?
Sir, pricking kind of pain.
And
Right? Tingling.
Does it go somewhere from something from some area to somewhere else? It goes.
Yes,
Yeah, it is a
sir.
radiating pain. Radiating pain. Okay, if it is a neurogenic, it is a typical electrical-like or a shocking and a radiating pain. Okay, and it comes in intervals. Comes in intervals. If it is a nociceptive cause because of the inflammatory process, it is a continuous burning or a throbbing pain. So if it is a second variety, after some period of time where everything settles, person recovers. If it is a first variety, it takes longer time or it may persist. So these are the two important categories where definitely you can predict and the first one you can definitely surgeon can prevent.
Yes, sir.
Okay. Yeah. Sir Lakshman sir, it
Yeah.
is time now.
I think it's
one
time.
or two videos. Yes, sir. You will stop, sir. I had in fact 2 videos I had kept to just to show them.
Please show
But,
them, sir.
next.
No problem. Please show them. Why we can see them, sir.
Same procedure. I thought of describing them.
Okay. Please
sir,
go
it
ahead,
will not
sir.
be late.
No, about 10 minutes more, it should be okay. So please show them.
It is seen, sir.
Yeah, it's seen. Yeah.
Just for the postgraduates, incision, usually preferred incision is Lange incision. What you people describe 2/3 medial parallel to medial 2/3 of the inguinal ligament. We usually avoid so that this is the ilioinguinal which is demonstrated over external oblique aponeurosis. You can see the nerve here. Then what you said, like taking incision all along the fibers. When you come on the external inguinal ring side, see that you don't cut the cord structures there. What is a nerve again? This is the sac. If the hernia is very thick with a thickened cremaster, you need to cut open that cremaster box. In this case, it is not hypertrophied. Straight away, it was released. Not to catch the vast difference. This patient had, in fact, a lipoma, not the indirect sac. So whether it is the indirect sac or the lipoma, they need to be tackled nicely till deep inguinal ring. If it is a sac, it is identified by external extraperitoneal fat. Don't try to hook the cord just blindly and try to lift up. That is the inferior epigastric artery which was seen. See that you get only the cord structures. It should not be a bulky cord before you start putting the mesh. That is the inferior epigastric artery. That is a lipoma, that is a cord. See that you have only the cord structures before you put the mesh. So it's a transfixation of the lipoma or the indirect sac after emptying, and see that it is completely empty before you do a transfixation. It's a direct sac. What Nikitha, what I was asking you, placation, this is exactly it should be done. Start from median, take a far away bites, push the summit of the sac inside, then do a placation. I insist that rather than taking a purse string suture, better to placate like this. If you take a purse string, if the sac is very big, probably you will not have a good inversion of the sac. So if you do a good placation, even if the sac is very big, nicely it can be pushed inside, so that you can place the mesh later nicely over the placated sac. Again, confirming the nerve. First bite should be a good bite. Keep at least 1 inch from the medial edge when you take the bite, the first site where you are going to fix the mesh. Because the calmest site for the recurrence after mesh repair is the medial end, medial side. When you take the bites over the inguinal ligament, don't try to pull the ligament up towards the wound. No, the mesh should go there because ligament is a fixed structure. Mesh should go there. If you try pulling that, then you will cut through the ligament. So the mesh should go there. You should guide the knot towards the inguinal ligament rather than the other way around. What Srikanth was mentioning, yes, medial side over the rectus sheath, you need to have a good fixation, 1 inch from the first bite, 2.5 centimeter minimum from the first bite. It has to overlap the lower rectus sheath. In case of direct hernias, you need to be careful when you take these bites. There are instances where bites can be intramural into the urinary bladder because it can be a part of the wall of the sac. So you need to be careful when you are dealing with sliding hernias. So laterally you are making a fish tail with the intention of creating new deep inguinal ring. This has to be overlapped. Those two tails should be overlapped and fixed laterally. This is the bite which fixes the lateral part of the lower leaf to the inguinal ligament. This is the U stitch. That is a muscle bulk. They again coming back to both the leaves. then that has to be pushed inside. Then that has to be fixed with a finger knot. This is the superior fixation to the conjoint tendon. This is approximation of split external oblique aponeurosis. See that you don't expose any part of the mesh. See that you don't prick the cord structures while doing this phase of the surgery. See that you take care of the external inguinal ring area, not to tighten the external inguinal ring. Again, you need to take care of that ileoinguinal arm which you have demonstrated in the beginning, not to take the bites between the two leaves. And the subcutaneous two layers should be separately closed, membranous and fatty layer. Okay. Yeah, this is all. I had one more. It's all right. Sir, anything, sir?
Thank you very much, sir. I
Yes, sir.
take this opportunity to thank Professor Shafiuddin, sir. Very nice of you to have joined us and taken part in the discussions. We would very happy to have all the people, the seniors, get in our discussions of the Sagar teaching group. We always have it online at 9 p.m. We will share the link in most of the WhatsApp groups that we know of. Very nice. I think we had an extremely nice and fruitful discussion. Closing remarks by Ravi Shankar, the HOD in Sagar, and then we'll close the session. Ravi, please.
Yeah, I echo the sentiments of Dr. Lakshman. I thank wholeheartedly. I thank Dr. Gurushanthappa sir for having come and moderated this session and also brought his students. I also thank Professor Shafiuddin from I think Gulbarga.
Yes.
Who joined the discussion and HIMSS Gulbarga. And thank you very much, sir. And thank you all the students and teaching staff, whoever joined. I'm not sure how many of you have joined, but we welcome you all for the everyday discussion which we have, subject seminar, general clubs and morbidity mortality meetings that we have, and also group discussion by usually by Dr. Lakshman. I would welcome you all for that. Thank you very much and good night.
And Nikitha,
One, sir, Lakshman.
Please
this
go on,
is
sir.
out of this what you call CME. This
No problem. Tell us, sir.
I think we should congratulate Gurshant also. He is occupied chair of principal KIMS Hubli.
Yes, yeah.
Okay.
We did that before we started the programs. Yeah.
Oh, sorry.
Yeah. No, it's very nice. I think it's a very nice sentiment. Yeah.
Thank you.
And Nikitha, I think you did a good job. Keep it up, and the fine tuning is always required, and that's where learned people, seniors guide you. But generally, I think you did a good job. Thank you very much, everybody, for joining this evening. Good night. I'll close the meeting.
Good night, sir. Good night, sir.
Good night.